Good afternoon. Thank you for joining us today. I'm Revati Prasad, the Executive Director of the Benton Institute for Broadband and Society. For those who may not know us, Benton is a 44-year-old nonprofit that focuses on broadband policy, working to make sure that everyone can use and benefit from high-quality, affordable broadband. Today, we're having a conversation about the relationship between broadband and health outcomes, exploring the multiple ways in which digital access and adoption can support health. We're also celebrating the publication of the Digital Access Coordinator Program Playbook, Digital Navigation in Healthcare, which is a new resource written by Dr. Jorge Rodriguez and his team at the Brigham and Women's Hospital. Dr. Rodriguez was part of our very first cohort of Marjorie and Charles Benton Opportunity Fund Fellows. We established the fellowship for our 40th anniversary, and through this, we support research projects by practitioners and academics, a few of whom you'll meet today, that help us understand ground realities, design better programs, and demonstrate what makes a real difference in people's lives. We were thrilled to work with Dr. Rodriguez over the last few years and are excited to be launching the playbook today. Quick orientation for today's events. We're going to bring everyone on and introduce you to our panelists. Dr. Rodriguez will then tell us a little bit more about the playbook and how other organizations can use it. Following that, we'll sort of zoom out and talk more broadly about how broadband availability, access, and adoption interact to influence health outcomes for individuals and communities. All right, I'm going to start bringing on our panelists. Dr. Jorge Rodriguez from Brigham and Women's Hospital led the Digital Access Coordinator Program, which embeds digital navigators within primary care teams, trains them to support non-English speakers, and extends outreach throughout community-based programs. Sarah Reza. Reza is at, this is a very long name, the Center for Health Law and Policy Innovation at the Harvard Law School. Reza is exploring how policy and legal frameworks help or hinder efforts to close the broadband healthcare gap, especially in rural areas. Recognizing broadband as a super social determinant of health, Reza is analyzing funding streams for healthcare delivery via broadband and exploring the barriers that prevent healthcare providers and insurers from expanding access to digital care. Reza is also a recipient of this year's Marjorie and Charles Benton Opportunity Fund Fellow. Thank you, Sarah. Sarah Jane Tribble. We have a Sarah and a Sarah joining us today. Sarah has been reporting on the lack of quality broadband and how it hampers healthcare in rural settings. Her investigation of dead zones found that nearly 3 million people live in rural counties where in-person care is extremely limited and telehealth is largely out of reach. Her reporting has demonstrated the real-world impacts of the digital divide on rural residents still waiting for better broadband. And last but not least, Dr. Rezi Agbo-Gerbhardt. Dr. Agbo-Gerbhardt studies the impact of broadband in historically marginalized communities. In a recent study, she analyzed disparities in health-related uses of the internet, including telehealth, drawing on data from the National Health Interview Survey. Dr. Agbo-Gerbhardt is also a member of the inaugural cohort of the Marjorie and Charles Benton Opportunity Fund Fellows. Thank you all for being here today. Jorge, at this point, I want to hand you the reins to tell us about the program and the playbook first.
Sure. Yeah. Thank you. Thank you so much. And I want to first thank Benton Institute for a wonderful opportunity and support to be able to understand the program a bit more and obviously put together the playbook. And two, I also want to thank the team at Mass General Brigham who runs the day-to-day of the program and all the digital access coordinators that actually are on the ground doing the work. I'm certainly presenting on behalf of all their work. In terms of the playbook and the program, as you mentioned, it really builds upon the great work in digital navigation outside of the healthcare system that's been done in the community and just brings it into the healthcare system. The goal of the program really started off with this idea as the pandemic was sort of at its peak, that we started noticing or it became evident that a lot of the gaps in a lot of our health technology tools were affecting our patients from marginalized communities. And so realized we needed to do something about this. And there we sort of learned more about, and then subsequently developed a bit more the digital navigation idea. We ended up calling our program the Digital Access Coordinator Program, but as I said, it's very much of the same as the digital navigation piece. I think the navigators, as you said, sort of have kind of two roles. One, some of them are sort of directly embedded within clinics, so they're part of the healthcare team, and some of them have more of a remote role where they provide more of on the phone or remote support to patients who may need it. And a lot of the focus of the program, at least initially, and that's sort of since changed a little bit, has been around enrolling patients in the patient portal, which is the main patient-facing tool that in the healthcare system. And to date, the program has enrolled more than 20,000 patients in the patient portal. I think that, when looking at the program, if you're kind of coming to you pick up this playbook and you're like, is this for me or not? I think a few things to think about. I'd kind of break it down across four ways to think about if you're a healthcare organization that is considering implementing something like this. I think one, thinking about your organizational commitment to health equity, digital health equity. Two, your understanding of sort of the digital kind of landscape of where your healthcare organization is. Three, looking at your own digital infrastructure, and then four, obviously staff capacity and funding. So kind of diving a little bit deeper into each of those. First, when we talk about digital health equity and organizational commitment, it's really defining what does digital health equity mean at your organization, and that can look a little bit different, depending on what your goals are. For us, it was very much focused on patient portals and to some extent telehealth, but to you, it may mean maybe deploying a certain mobile app that you've purchased, or looking at continuous glucose monitors or remote blood pressure cuffs, something along those lines where it aligns, and making sure that you then have the kind of clear mission and leadership to support that. And then along with that, and sort of informing that, is sort of your kind of understanding of the digital landscape and also health landscape within your health organization, really deciding where are the healthcare gaps, and when and if does technology play a role in addressing some of these gaps. And I said three, your own digital infrastructure within the healthcare organization is key. Having those, let's say it's a patient portal leaders that can really become partners as you're developing your digital navigator program, because there'll be a lot of communication between the folks who run the patient portal, for example, and the digital navigator team. And then last but not least is obviously the staff capacity and funding, which is often some of the biggest challenge, I'd say. And that can look differently for everyone else. For some places, it might mean you have funding available through your organization. Sometimes it might be grant funding. Sometimes there's no funding at all. And we've spoken to other organizations that have done it using students or volunteers, or working with community organizations. And so that sort of helps address kind of the staff and capacity piece of the puzzle. And then a lot of this obviously all relies on being able to kind of capture data. And in the playbook, we go a little bit more in depth into like what that data capture looks like. But I think, as I said, kind of highlighting these four things: what does your commitment to digital health equity look like? What's your understanding of the landscape? What does your digital infrastructure look like? And what does your kind of staff capacity look like? Answering those kind of questions will help kind of set you up to see, will I be able to kind of deploy this type of program in my organization? And of course, all of this addresses one piece of the puzzle. And as I'm sure we'll get to in the rest of the panel here, there's all sorts of other pieces that are important, broadband being included. But I'll stop there.
Thank you so much, Jorge. So tell us a little bit, part of your data capture was talking to the digital access coordinators themselves, your health navigators. I was wondering if you could talk a little bit about what they experienced or what their perspective was on being part of the pilot program.
Yeah, I think it's interesting. Some of the navigators that started off earlier really felt that like, oh, this is pilot, we were kind of learning. And then as you see the navigators who joined later, and I should say at this point we're at 10 or 11 digital navigators. And so the ones that started later felt a little bit more of like they had that support of the folks that started earlier. I think that a lot of what the navigators said, some of it was kind of like supported what the numbers showed. So a lot of our numbers showed that, for example, patients who were older struggled a bit more with some of our technology tools, and the navigator said that as well. But I think what was interesting there was that they were able to say like it took a little bit more work, but sometimes it was it became almost more satisfying to them when they got this older person who was really struggled at the beginning, and then once they got through it, they're like, oh wow, okay, I can do this. And I remember one navigator describing a story where a patient was like almost like very anxious, like surprisingly very anxious about. They're like, "Oh, is this for me? I'm not sure if I can do this." And the navigator was able to work through them with it and get them set up. And by the end, they were able to use it. So I think that was one of the reflections. And then the other piece that I think the navigator shared with the importance of and feeling of becoming part of the healthcare team, because I think what is so important, especially in healthcare, is the kind of the power of the word of the clinical team, whether that's the doctor or the PA or the NP or the nurse, the medicals, whoever it is on the healthcare team, having them kind of tell the patient, hey, we have this portal, we have this telehealth program, whatever it is. We know you might, but we're wondering if you might be set it up. I know you're a little bit hesitant to it. We have this person, this navigator that can help you set it up. That sort of like pass off, as we refer to it, really helps kind of patient get engaged and interested in it. So I think that's something that they reflect to us as well, just like the importance of just being part of the team and viewing this technology and navigator program as like part of care rather than like an add-on that like, is nice for some people, but not for everyone.
That's really interesting. It really helps clarify how you want to establish a program and where you want it to sit. I want to bring on our remaining panelists and sort of switch our perspective from what an individual healthcare organization might do to support digital inclusion to sort of the overall landscape of broadband availability, access, adoption, and health. Quick reminder for anyone watching this on YouTube, please know that you can submit questions for any of us as a comment, and we'll make sure to save some time towards the end of the webinar to include those. Okay, so thank you everybody for joining me. I'd like to open our discussion by thinking together about access to broadband and access to healthcare together. Sarah, I was wondering if we could start with you, because you have focused your work on broadband as a super social determinant of health. What does that term mean, and how does it help you conceptualize the relationship between broadband and health outcomes?
Yeah, absolutely. So, as we all know, the impact of broadband on healthcare access and as a result, health outcomes is clear, direct, and compelling. And this really significant and direct impact of broadband on healthcare is why we are increasingly thinking of broadband as a social determinant of health. Now, just to level set, what do we mean by social determinants of health, or SDOH? These are basically the conditions in which we live, learn, work, play, worship, and age that shape our health and quality of life. Things like access to education, stable jobs, safe housing, and transportation. All of these influence how easy or hard it is for someone to get healthcare or for someone to stay healthy and get the care when they need it the most. And when we call broadband a super social determinant of health, what we are really saying is that it doesn't just impact health on its own, like enabling telehealth, but it also affects all those other factors that I just mentioned. It helps people access food assistance, housing support, transportation resources, and so much more that indirectly shape and drive our health outcomes. So, to help conceptualize this relationship a bit between broadband and health, I use the example of how having access to the internet lets you do a telehealth visit or use remote patient monitoring tools like Jorge was just mentioning. And that is our direct link to healthcare. But having access to the internet, on the other hand, also helps you apply for government benefits online, such as SNAP or housing assistance, all of which are that indirect connection of broadband to healthcare and indirectly helping improve our health outcomes. And that is why broadband is increasingly being recognized as a super social determinant of health.
Thank you, Sarah. Rezi, you've been working on a study about who uses the internet for health-related tasks. Could you tell us a little more about your findings and what the strongest predictors were in the National Health Interview Survey for using telehealth?
Absolutely. So I examined the 2023 NHIS data, and my goal was to analyze the data to see who was using the internet for different health-related tasks. I focused on 4 health-related tasks that I measured in this survey: telehealth, communicating with a provider, searching for health-related information, and retrieving test results online. I was really interested in understanding the disparities across different subpopulations, if any, in using the internet for those tasks. And for that work, I focused on adults that already had internet access and had seen a doctor in the past year. And I controlled for other factors that affect healthcare access in the US, such as having medical insurance or having a chronic disease. And what the results showed is that many of the adults belonging to the Digital Equity Act covered populations experience a third level digital divide related to health outcomes. So that means that there is a difference in the outcomes that they get relating to health from using internet access or from their internet access. So I found that education, gender, and urbanization of their area of residence were the strongest predictors across all of those 4 health-related internet uses. So just to dive in a little bit to kind of talk more about the significance of the disparity, compared to adults with a bachelor's or higher, adults that had no more than a high school degree were about half as likely to use telehealth. They were almost 4 times less likely to search for health-related information online, and about a third as likely to communicate with a provider online or to retrieve test results online. And then when we look at gender, my work saw that women were more likely to use the internet for healthcare than men. They were 40% more likely to use telehealth. They were about 46% more likely to communicate with a provider online. And they were about 60% more likely to search for health-related information or retrieve test results online. And then when we looked at that urban-rural divide, we see that gap actually when we look at health outcomes. Compared to urban residents, adults living in rural areas were about 40% less likely to use the internet for telehealth or for retrieving test results online. They were about half as likely to communicate with a provider online and 27% less likely to search for health-related information online. So while these largest disparities that I found were along the lines of education, gender, and type of urbanization of residents, there were a couple other interesting findings that I want to highlight. One was when we looked at those adults that had a disability and those that do not, I found that adults with a disability were almost twice as likely to use telehealth compared to those without a disability. And they were about 25% more likely to communicate with a provider online compared to adults without a disability. And then when I looked at race, because we know that race and ethnicity is one of the predictors of using internet, interestingly, I did not see significant difference in telehealth use across race and ethnicity lines. But when I looked at the other health-related tasks, I found that Hispanics and Blacks were significantly less likely to use internet for those other tasks.
Thank you. So just to be clear, when you said folks in rural areas are 40% less likely to use the internet for health-related tasks, here you were talking about people that already had internet access, right?
Yes, that is correct.
So that's really interesting. And it actually connects me to Sarah Jane here. So in our broadband world, we talk a lot about access to broadband, but your work on dead zones is really interesting. So you've covered these places that are both healthcare deserts or lacking in primary care providers and behavioral health specialists, and broadband deserts that are lacking in high-speed, reliable internet. What can these dead zones tell us about the relationship between broadband and health outcomes?
Yeah, thank you for having me in this panel, and thank you for asking the question. I am being a reporter. I have to ask though, for 40%, those adults, did you get the broadband speed that those adults were accessing overall? I'm curious if, what I found out in my reporting is if you had speeds that were lower, that it felt like you were using a dial-up phone as opposed to what many of us have in urban areas where we pick up our phone and we can flip through the New York Times or to our Facebook page immediately. But if you can't do that, if it's like a dial-up, you're much less likely to use that internet. So I'm curious if the 40% of adults, if that 40% was in some way, if you measured the internet speed when you were doing that research, if you don't mind me asking.
Oh no, I'm happy to talk about it some more. Unfortunately, the data set did not measure the internet speed, so the quality of the connection, and that's one of the things that I was going to actually mention. But yes, it's one of the unknown that could impact, or I would say, additional cost of connectivity that even those that are connected face, which is the quality of internet access that you have.
Yeah, no, I do think quality of internet access is a very important point. So the work that we did was based off of a hypothesis I had after visiting my parents in rural Kansas. And that was the hypothesis that folks in rural areas were less likely to use telehealth because they didn't have internet connectivity, and they were more likely to need it because there's known shortages of providers in rural areas. So what we did here at KFF Health News is we worked with our data analysis. Holly Hacker is our data person, and she worked with FCC broadband data, the latest Fabric data, which requires speeds that are fast enough for telehealth. And then we also worked with George Washington University and their academic teams on data that showed the number of Medicaid primary care physicians, so those who were treating lower income and disabled residents in the U.S., as well as all behavioral health care providers. And we overlaid the data on top of each other across a map across the U.S. and found that there were millions of people, as mentioned previously, of about 210 counties across the U.S. met the criteria of lacking adequate amounts of high-speed internet at 100 over 20 megabits per second, and healthcare providers, both primary care providers as well as behavioral healthcare providers. And so the hypothesis proved true that there are millions of people across the U.S., mostly in rural areas, and those areas were mostly, you can see big swaths in the rural South as well as Appalachia and the remote West. Not a surprise to anybody on this call, probably. And we overlaid that with some CDC data and other health outcomes data, and saw the correlation that other panelists here have mentioned, the fellows have mentioned, and that is that people live sicker and die younger in those counties. So that's sort of the summary of what we worked on, and I can provide examples of many of the people I interviewed as well.
Yeah, we would absolutely love that. I also want to actually bring in Jorge at this point as both a clinician and a healthcare researcher. How are you seeing the disparities in who uses the internet for health-related tasks play out in your work? Because Rezi and Sarah have both sort of alluded to it at this point.
Yeah, I think as I mentioned, I think we see this sort of alignment between lacking access to the internet or broadband and a lot of worse healthcare outcomes, which often creates this kind of conundrum, this conflict here, where you're sort of pitching technology as this very important tool that everyone should have, and it's going to sort of improve a lot of our care. But then we're seeing that the folks who often have worse health outcomes are not having access to it. And I think it really reflects a little bit of like that kind of classic diffusion of innovation curve, where we're sort of, unfortunately, the sort of like laggards of in this diffusion curve are the folks who really could benefit the most from being the kind of the early adopters of this. So that's sort of one area. The other area that I'll mention that perhaps is less focused on is the importance of clinical trial participation as sort of a researcher. So a lot of, when you think about a lot of these studies, a lot of times they're even moving remotely, or you require some sort of remote connection to engage with, or even to look up, right? Going on clinicaltrials.gov and being able to look up clinical trials, all of that requires internet and broadband. So I think as a researcher, that's often a question that comes up for us. If we're deploying any sort of new trial, especially ones that use this technology, like that's always a question: how will we address people who don't have access to the internet or don't access to the device? And then that obviously has downstream implications, because as we've all sort of mentioned, there's sort of certain demographics that don't have access to it, and that all leads to sort of lack of appropriate representation in clinical trials. And if they're not appropriate clinical trials, maybe we're not developing the right intervention for the right people, the right drug for the right people. So there's sort of like larger implications, even without just like care delivery, but actually sort of generation of new data, new information through clinical trials. That's really impactful.
I hadn't even considered that. That's really interesting. Can we talk a little bit? You mentioned some digital tools and apps. I was wondering if we can talk a little bit more about how healthcare relies on digital tools. So what does broadband enable? in terms of tools, treatment modalities, applications that can help improve patient care?
Yeah, so I think, obviously we mentioned a few of them, the telehealth and patient portals being like the most common ones. I think remote blood pressure monitoring is essential as well. And one area that I've been thinking a lot about, so I will talk more about, is in the treatment of diabetes, the use of continuous glucose monitors. And so for those who don't know, continuous glucose monitors are sort of devices that you can attach to your body, usually to your arm, that measure your sugar levels every few minutes. And the importance there is kind of multifold. There is one, it helps patients who may need sort of like multiple times a day finger sticks. If folks have ever pricked themselves for blood, it can be pretty painful, and so doing that 3 or 4 times a day can be pretty painful for folks who need to do that, like patients with diabetes. And two, one of the big things that happens at the clinical level is making decisions around whether to increase a medication, decrease a medication, usually relies on either one lab value, which obviously is not great, or if the patient is able to bring in their sugar levels for the past week, but that's really challenging. And so these sort of tools allow you to sort of upload automatically a lot of this glucose information, sugar information into sort of like a usual internet platform for your clinicians to review. And those are the kind of things that patients can miss out if they don't have access to broadband. And I think it's important to reflect of like, and similarly, blood pressure monitoring is the same thing, right? Like if you have a blood pressure monitor at home, rather than sort of relying on like the one blood pressure that you get in the clinic after you just like ran up the stairs because you were running late for your appointment, and then you sat down, someone took your blood pressure, and you're like, oh, your blood pressure is high, but turns out at home you're not. So all these kind of things really are important and rely on broadband. And I think the move in the healthcare system is increasingly towards technology, and with that relies on internet and broadband. And so as a clinician, it just can create sort of like a data gap for me. And so I'm sort of making clinical decisions probably with suboptimal data for some patients, all because they didn't have access to the internet, which obviously is, as a clinician, I don't want to do that. I don't want to make suboptimal decisions. So that's how we can impact sort of care down the line, and how all these different modalities come into play.
Sarah, in your reporting, you saw that dynamic play out very tangibly in people's lives, right?
Yeah. So we actually decided to focus on diabetes as the illness that would be an example showing the disconnect between people who had high-speed internet and who lacked it. And I talked with a woman named Barbara Williams in Greene County, Alabama. She's in her 60s, and she's had diabetes for a number of years. She doesn't know exactly how long. She works with a provider locally, but she does not have remote patient monitoring. And she hadn't pricked her finger in a month before I went to visit her. And she was comfortable with her medication, but she worked off of feel, right? Like if she felt dizzy, she took or fainted, lightheaded, she took a peppermint. And I don't know all the clinical outcomes here because I'm not a doctor, but I do know that when I went to interview her that morning, she was cooking food for lunch, but she hadn't really sat down in the morning. And as we were interviewing, she had to go and get a peppermint because she felt lightheaded. But she told me she had her diabetes under control. Now, when I tested her internet connection, it was negligible. It was terrible. And I tested it because she has a cell phone and a wireless router in her house that she uses to check Facebook and go on a prayer meditation app. And so it's good enough for her. But she certainly doesn't have a remote patient monitor. She isn't tracking her glucose levels. And so when she goes to the doctor, it is that one-time thing. She has neuropathy in both legs, and it is getting worse.
Thank you. Sarah, we've talked a little bit about diabetes care and clinical trials. I was wondering if you can talk about, I think you had mentioned cancer care as being positively impacted through broadband access. Could you tell us more about that?
Yeah, so over the last few years, we've spoken with a wide range of cancer care stakeholders, from large comprehensive cancer centers to smaller community-based providers. And we have seen that within the context of cancer care, telehealth has applications across the care continuum. And just a disclaimer that telehealth is not possible without broadband access. So telehealth can be deployed as part of screening, an example of which is virtual shared decision-making appointments as part of treatment, which includes second opinions, behavioral health, tools, provider-to-provider consultations, virtual check-ins. Then telehealth has applications throughout survivorship, which is like really facilitating transitions from specialty care back to primary care, and in non-clinical wraparound services. So that includes navigation, peer support, health education. And while telehealth has like applications across the care continuum, we've also seen that like cancer care is often extremely intensive for patients and their families, leading to both like time toxicity as well as financial toxicity. So because of this, there is significant interest in strategies to reduce direct and indirect costs. And that can really happen by expanding access to broadband, because research shows that telehealth has a positive impact on patients by saving them the time and money traveling to and from medical visits. In our conversations, we have also seen interviewees highlight that telehealth does not need to supplant in person care. Patient choice really has to remain at the heart of the care process, and not all aspects of care can be delivered via telehealth. And one recurring theme that kept coming up in our work was really that patients should never be forced or pressured to choose between in person or telehealth visits, especially when the medical benefits of both are the same. So, really reiterating that patient choice has to remain at the heart of the care, and it is the provider's responsibility to make sure that these policies and regulations that protect that choice are upheld. Because a lot of times patients feel more comfortable seeing their doctor face to face. It gives them that peace of mind. And one way of really like addressing that in cancer care, which really depends on telehealth, is that providers can play a key role in helping patients ease into online care, and they can create like helpful resources, patient friendly materials that can help patients navigate their cancer care journey, whether it be through digital health navigators or through teaching them digital skills. The role of the provider is critical in throughout the cancer care continuum.
Thank you. Rezi, tell us about how disparities in telehealth use that you mentioned earlier, how have they evolved during and after the pandemic, specifically among the demographic groups that you looked at?
Yeah, thank you for that question. So I looked at telehealth utilization between 2020 and 2023. And of course, in the early days of the pandemic, there was a very sharp increase in telehealth utilization, because that was basically pretty much the only way that you could get access to healthcare. So we saw that sharp increase, but by 2021, on average, across all populations, we kind of began to see a drop in telehealth utilization. And then when I looked at different demographic socioeconomic groups, a few of them I could see disparities in the change between groups over time. Now, earlier I talked about, the different disparities that exist between different socioeconomic groups or demographic groups. But then I looked at over time, did that disparity change? And for a couple of them, or for a few of them, I could see a change in disparities over time. I'm just going to talk about two that are very interesting and I would like to highlight. The first is looking at those with disabilities and those without. So when I looked at only the 2023 data, I saw that those with disabilities use telehealth more. And then when I looked over time, I actually saw an interesting finding where those with disabilities consistently use telehealth more than those without. But when we also looked at that after the peak in 2021, and we began to look at how the decline of telehealth utilization changed over time, I found that those that did not have disabilities reduced their telehealth utilization at a steeper rate or a faster rate than those with disabilities. So we see that those with disabilities continue to rely more on telehealth than those without. Another socioeconomic group or demographic group that I thought was very interesting in the way their disparities change over time was when I looked at educational levels. So those with higher educational qualifications, those with a bachelor's or higher, use telehealth more. But when we look over time, we see a concerning result because we see that the disparities between those groups was increasing. So those that have a bachelor's or higher continue to use telehealth at a higher rate than those without, or those that completed no more than high school. We saw a steeper decline with those that had lower educational qualifications.
Thank you. We've talked a little bit about how broadband access is crucial across the care continuum, as you all were saying, clinical trials, chronic disease maintenance, the social aspects of having a severe disease like cancer. I'm wondering if we can talk a little bit about not just the ability to access, but the ability to afford your monthly subscription and how that shows up in health outcomes. So, Arezi, I know you've done a lot of work on the broadband affordability burden. Can you talk a little bit about how you saw that present itself in terms of health outcomes as well?
Yes, absolutely. But I kind of want to also step back a bit and kind of look at it with a broader lens. Because a lot of times when we think about the affordability burden, we think about the cost of broadband and the cost of the devices. And a lot of times we think about those who are unconnected. But as Sarah and I were kind of talking about earlier, we also need to consider those who are connected, but are facing some type of cost, some type of affordability burden that even persists after connectivity has been achieved. And we see that when we look at, or when we think about things like the cost of technology maintenance, the cost of the quality of internet access, the cost of, I guess, how many people are relying on a single device in a household. So these are some of the other ways that we need to think about the affordability burden. And when I looked at, I think I'll again center back to the work that I just did, which although it looked at those who were already connected, I could see that there's a significant disparity in telehealth use between those that are more wealthy and the low-income adults. So that kind of begins to suggest that even among those that are connected, there still is some type of affordability burden that could be impacting health outcomes. Again, not to discount those who are not connected at all, who I did not even look at in my analysis because I focused on those who are connected. But in the US, it's about 6% of adults that are not connected to the internet, which represents about 16 million adults. And so when we think about that and we think about some of the factors that has been shown in the literature that are the key barriers to connectivity for those adults, we know affordability is one of the top barriers. So that's one of the things I just want to kind of highlight, that we can think about this as those who are unconnected, but even for those who are connected, we're still seeing disparities in health outcomes. Talk less of those who are not connected and don't have an opportunity to access telehealth. Right.
Yeah. I wonder if sort of the steep decline that you noticed in telehealth use after the pandemic would be even more pronounced after the end of the Affordable Connectivity Program, because that was a subsidy program that was run during the pandemic that at the consumer level reduced the broadband bill on a monthly basis. And Congress didn't reauthorize that. But I know, Sarah, you had done some reporting on the ACP. Could you talk a little bit more about how you saw that impact people's health-related use of the internet?
Yeah, and I think Arezi is so spot on, because when I was reporting on the ACP, the Affordable Connectivity Program, I think it was 23 million households in the U.S. who finally had signed up for that. Please correct me if I've got the second digit a little bit off, but more than 20 million households in the U.S. had signed up for the Affordable Connectivity Program. And one of the statistics or data points that I found interesting, I don't remember the number, but the program subsidized households at $30 a month, or in some areas up to $75 a month, for instance, if you lived on tribal lands. And what it did is it subsidized your internet subscription. So it would pay your bill, basically. And lots of people would get maybe free bills or almost nothing. And what they found with that program is that the cycling on and off by the month, so many people who don't have very much money, they will cycle on and off internet connectivity and phone connectivity because they can't afford to pay their bill, 1 month or 2 months, and they'll sign up for a different carrier. And so they found that sort of detrimental on and off again with the internet stopped because they had a program that helped pay for their monthly bill. And so I think that really gets back to what Arizi was saying, is that the affordability is just as important as whether you can access it or not in sort of the tangible form, and if you have access to wireless internet or broadband on the ground too. And as far as health outcomes, what I found talking to just citizens in rural areas, including on reservations, is that they were thrilled to be able to afford the bill so that they could log on, even if it was at a slow rate, to check their banking or to send a note on a portal to their doctor. I think it made a big difference to them, and they got to see exactly that access that they could have and how it could improve their lives.
Thank you. I'm going to make a shout out to John Horrigan, who is watching. Thank you for your question, John, and I'll make sure we get to that a little later. But he's done the work that you were talking about, Sarah, on the subscription vulnerable, as he calls them, the folks that are constantly churning on and off, who can maybe some months afford their broadband bill, but maybe not so much on another month. Speaking of the Affordable Connectivity Program, we saw that the ACP was not reauthorized. At the federal level, we've also seen the cancellation of the Digital Equity Act, a program that would have likely included a focus on health-related broadband efforts. There's also an ongoing budget fight happening right now. I'm wondering, Sarah, if we can start with you, what kind of policy interventions have you seen or are part of the discussion to improve broadband service to rural America? And in general, the places you explore in your Dead Zone series.
Oh, goodness. That's a big question. And I will say the Dead Zone series was bolstered by many, many phone calls and emails to John Horrigan for advice. So I just want to shout out John momentarily. But yeah, so, I asked a researcher at Pew the question of how much money has the U.S. government spent on programs to try to bolster internet access, just to build the infrastructure for it over the last decade or so. And there have been government accountability reports on this and so forth. And it's really hard to tally up because the latest GAO report found that there were 133 different programs over 15 different agencies in the U.S. government. So you're talking USDA, FCC, NTIA. I could alphabet soup it for you all day. But the latest one that's in the news right now is a $42 billion broadband equity. It's the Broadband Equity Access Digital. I'm not going to get it right now. I should have it memorized. I was just typing it. But it's a $42 billion program passed underneath the Biden administration as part of the big Infrastructure Act of 2021. And it is, it's 3 or 4 years into it, and states have been remapping, and they have been putting together plans to get internet to all, which was the focus of that program, with a priority on fiber lines, which are the sort of lines that go on the ground and over aerial poles. However, when the Trump administration came in, they have said they wanted to do a rigorous review. They put the program on pause, and they've announced new guidelines recently that will have states going back and having redoing some of it. And there's a lot of kind of disarray about the program right now. So that's sort of the big policy thing. There are other programs, too, that were part of the Infrastructure Act, like the Digital Equity Act, which helps with digital navigators. And I haven't done as much reporting on that, so I won't speak to it, but maybe some others on the panel can.
Thank you. Sarah, I know you've been looking at some policy interventions that can improve telehealth use for in rural areas, specifically the rural Black South. I'm wondering if you've seen interesting policy interventions that you'd want to highlight right now.
Yeah, I would say that like there's definitely a lot of interesting things going on both in rural areas and urban areas. Like one interesting thing that I would flag is like California just recently introduced a bill in the Senate titled the Virtual Health Hub for Rural Communities Pilot Program. And if approved and enacted, this law will require the California State Department of Public Health to administer the Farm Workers Health Equity Fund to expand access to health services for farm workers, particularly in rural communities. And this would be done by providing virtual connections to healthcare providers, mental health services, and educational services aimed at improving health outcomes in underserved communities. And the State Department would offer grants to community organizations to administer the program and will provide technical assistance to community organizations regarding any licensing or reporting requirements necessary to fulfill the obligations of the program. And just to clarify, the virtual health hub is defined as a vehicle or a portable facility equipped at a minimum with computers, Wi Fi, cubicles for virtual visits, and exam rooms for telemedicine. Additionally, any organization that receives these funds would be required to deploy virtual health hubs into rural communities based on farm worker population and access to healthcare. And this really touches upon so many of the interesting things that we have already talked about in the webinar, which is affordability, access, infrastructure, deploying and using digital health applications, and then an overview of social determinants of health, right? So this opportunity or this healthcare delivery and financing mechanism is not just aimed at improving someone's physical well-being, but in fact is a way to help farm workers get connected to educational services as well as healthcare access. And I think that is pretty great. Seeing if this like becomes law, it's going to definitely have a huge impact on underserved communities.
That's good. That's interesting because there's also a divergence here, because recently the administration canceled at the federal level all sort of under healthcare funding, everything that wasn't directly healthcare. So broadband funding for a lot of other programs got slashed because they weren't directly related to health, in the administration's understanding, at least. One thing that I wanted to bring up, which is sort of a pivot away from what we've been discussing so far, is that the question around trust and privacy and health misinformation. So we're at this point in time where distrust in institutions very high, and the general experience of being online as being subject to scams and threats to privacy, et cetera. What do healthcare organizations need to take into consideration when it comes to people who are very rightfully wary of the digital world and sharing healthcare information, which is obviously deeply personal and potentially very sensitive? Jorge, I was wondering if that was something that came up for the digital access coordinators, for instance.
Yeah, that's definitely a theme that's come up in terms of when it's sort of been an interesting piece around just like patients' understanding of what happens to their data and their information. And so some patients have been surprised by the fact that their information lives in this place called the portal, and then you can access it. And they've been concerned about, can anyone access it? Is it just me? How do I know it's protected? And so they've been a little bit surprised that it even exists. So I think that's definitely come into play. And so some of the role of the digital navigators have been kind of acting as like brokers between like the digital world and creating almost like a human face that creates that trust to be like, this is a trustworthy place. Obviously that, that sort of is, the foundation of that is having a healthcare organizations make sure they're abiding by all the different sort of privacy policies that we have in healthcare. And also, I think, especially when you're using kind of third-party vendors that might, have like different internet platforms, making sure that those privacy policies are pretty clear. There's sort of data, if you start looking at data for privacy, where either third-party applications or even some of the like the COVID apps that were used during the peak of the pandemic would actually share information with third parties like Google or Facebook or whoever it is. And so having those kind of like policies clear, I think is important. And for me as a clinician, for patients that for multiple reasons may worry about their privacy, and the fact that I'm monitoring them remotely, may expose where they are, right? Then that can pose all sorts of potential challenges for them. So for me as a clinician, it's important for me to know this information is going from point A to point B, the patient and to me, and there's no one in the middle that's trying to look and see. And so I think it's important for that to be clear. As for healthcare organizations, just need to have that clear, that privacy policy, the compliance officer, the privacy officer needs to be deeply involved in this to make sure that we're not, spilling information where it doesn't need to go.
Thank you. Sarah, or Rezi, did you all have thoughts you wanted to share around the questions around privacy and safety online using healthcare?
So I think this kind of comes back to Jorge's work, but a lot of the work that I have done when we talk about digital inclusion, which is basically what this, at the core of this question, that's what it comes down to: digital skills, familiarity, confidence in digital systems. When it comes to digital inclusion, one of the best practices really is, well, I'll say two. People are different, and that's something that we need to remember. So even when we talk about the covered populations, we talk about seniors, we talk about those for whom English is not their first language, their needs are different, and there's a need to tailor support to those that need it, right? And so when it comes back to the question of what do healthcare organizations need to what the healthcare organization needs to take into consideration, I think that it's important to remember that the fears that these people have is real. There's a lot of backstory to their fears and their concerns. And so having support in place, having culturally relevant support is I think is important for them to consider that. Make sure that their patients have the support that they need to help them navigate using these technologies.
Thank you, Rezi. I want to be able to make sure that we are bringing in questions from our knowledgeable audience. And Sarah, you probably saw this, but a couple of folks helped you remember what BEAD stands for: Broadband Equity, Access, and Deployment. That's what the D is for. Don't worry, we all forget it too. We're just so used to calling it BEAD. Two of the folks have brought up questions around the burden of cost. So Christopher Feld asks, who should share the burden of cost to provide broadband services to those who are unconnected? And in a similar vein, which may actually presage the answer, any learnings on the cost savings for healthcare if digital is integrated into monitoring and delivery services? And I was wondering if any of you had done work or had seen work around cost and broadband access.
I can jump in mostly to say I think it's an interesting question. I think that the concept of cost, sometimes I'll say it's important to look at cost. Sometimes when we've looked at Navigator program, for example, cost is part of the evaluation piece, but also it's sort of there's all these other pieces around patient satisfaction and patient sort of just staff satisfaction that also come into play. I think that in terms of who should share the burden of the cost, I think if we, and this is purely my opinion, I think if we are really committing to being a society that's putting technology first, and we're AI is going to do this and we need to do all this stuff, then I think to some extent we're sort of saying we're committing to this. We need to bring everyone along to be able to participate in this kind of technological society, and by not covering the cost. So that's why the loss of things like the ACP is such a big hit, because on the one hand, you're sort of saying technology is the answer. On the flip side, you're saying, but not for everyone. So I would say that I think funding like the ACP is critical to getting all this done and providing that extra support people need, because as we've mentioned, it has implications throughout kind of not only healthcare but throughout people's lives.
I'll piggyback on that. And just with my reporting across the country on this project, I've been to West Virginia, Alabama, Idaho, talking to people in their homes. And and there's been a lot of good reporting on this and a lot of good work on the cost aspect. I've been focused on the health outcomes aspect of it and speeds and so forth. But the cost aspect strikes me because I would talk to people who had very slow internet connections and they were paying $100 plus or $80 plus for an internet connection that was not nearly as good as something you could get in an urban area like Howard County up in Maryland, where there's 99% of people in that county have access to high-speed internet. And so what you see in these rural areas and often in places of where more people of color live, there are higher cost plans and lower connectivity speeds. And there's been lots of work on that, so I won't quote it off the top of my head, but it's out there. And then just to sort of piggyback on what Jorge was saying even further, the Affordable Connectivity Program is one thing, but I interviewed Ross Duvall, who is at the Heartland Institute in Arkansas, and it is a economic development think tank, so to speak. And he really put into frame by saying, and he wasn't the only one, but he said, this is like rural electricity. It's like the rural electricity program. You put electricity to all these homes across the U.S. They had access, and it increased their economic viability and their ability to participate in the modern world. And what many policymakers and experts see broadband as is exactly that. It's like the next step to rural electrification. It's just connecting people to the internet now. And I think that's a really interesting way of looking at it from sort of a who pays for it question.
And if I may add to what Jorge and Sarah said, I think it's such an interesting question about like who shares the burden of the of cost, because I think like healthcare doesn't really exist in a vacuum, and it's not a standalone issue. What's really important is that we sort of understand what is impacting our health outcomes. And that is not just like, our access to care, but like I said, and if I had a dollar for every time I said this, that health broadband impacts so many other social determinants of health, so many of the other factors that impact our health outcomes, that at the end of the day, it's really about who are the stakeholders involved that are helping us get to that point, right? Where we are connected, where we have access to care. And I think healthcare and social care both go hand in hand. And what I mean by that is we need to coordinate services that address both medical needs and essential supports like food, housing, employment, social connections, so that they are perhaps provided ideally through a single point of contact. Because what's going to be helpful is understanding that a person's overall well-being is not just like their medical conditions, but it's dependent on their social circumstances, their personal needs. And a community health center or a community anchor institution can provide that access to telehealth, which is not just consultations with your physician, not just access to virtual health, but also embeds in it a platform or a governance system where patients have access to other resources like housing support or food assistance, mental health services, and are working side by side with social workers as well as community health workers to really bridge that gap. And I think if the system exists like together in harmony and health and social care are working hand in hand, we can really see some great improvements in our health outcomes and share cost.
Thank you, Sarah. So that would be a lovely note to leave it on, but Jorge brought up AI, so now we are obligated to say something about AI. So this is a question open to any of you, but as we hear more about the use of AI in healthcare, how do you think it's changing the relationship between broadband and digital tools? Are there specific uses that you find interesting and others that potentially you're concerned about?
Yeah, I'm happy to take it. And we've seen like AI come up a lot in our work. AI becomes more and more integrated into healthcare every single day, and reliable broadband access is really like crucial, is essential for both patients and providers. And we saw this with the rise of AI, where we're seeing a shift with even more care, especially low acuity visits that are being delivered virtually, potentially with AI driven tools, and then what people may call AI doctors. And what could happen without broadband is that patients could be locked out of this basic tier of care, which is probably going to deepen the disparities that already exist. And additionally, we have also seen AI show up in areas like digital phenotyping. And a good example of this is Alexa or similar devices that can monitor speech patterns and flag early signs of cognitive decline. So, for those tools to work as intended at their full capacity, I think it's so important to rely on stable, high speed internet. And lastly, I'll say that AI in healthcare does bring some serious risks. So, take prior authorization, for example. AI is being used by health plans to review requests, but rather than cutting down on unnecessary care, it is often adding to that physician burnout and their workload, not delivering the promised benefits. So we need really like an AI governance system built for helping people understand how AI actually works instead of just retrofitting to our existing medical device framework. Because in healthcare, the stakes are just too high for us to get this wrong.
Thank you, Sarah. I'm going to pause for just a second to see if anyone wanted to add something to that. We are over time, so I should be wrapping up. Thank you so much to all of our panelists and for those of you watching today. We can put up our contact information on the screen. If any of you have any questions or feedback, please feel free to reach out. And you can, once again, find the playbook that brought us all together on our website. And thank you for joining us today.
Thank you.
Thank you.
Thank you all.